Welcome, welcome, welcome. This is your perimenopause and menopause education series, Menopause Explained. You hopefully watched my intro video, which gave you a little bit more information about me and how I ended up coming to this point, et cetera, what I'm doing now. So I want to move forward with just giving you a little bit. This is just my little bio, very short bio, but watch the intro video if you haven't. So I want to just make sure you know that um, this is the disclaimer disclosures I have to give you really every video at the beginning. And this video, there's no editing, there's no pausing. I'm not pausing what I'm recording or telling, changing what this is just, I'm presenting to you. So forgive if I have to correct what I say or misspeak for a second and fix what I said. So, but just remember, this course is not medical advice, it's education. And I really want you to learn from this video series and then take that with you to your provider, be it a doctor, a nurse practitioner, a physician's assistant, um, and take that information and use it for yourself to help yourself. So that's really my goal here. This doesn't create a doctor-patient relationship with you. And I'm also not affiliated with any drug or drug company, laboratory, or imaging company. So if I tell you, hey, you should go get this done, it's not because I have stock in any of those companies or that they're paying me a fee for a presentation. All right, so Module 1, Intro to Perimenopause and Menopause. Now, some of you who may have done some reading may find the information in this video, um, you know, too basic for you. Maybe you already know all this information. That's okay. There might be some things you haven't heard before. So listen in. You don't have to be sitting glued to the screen. You could be just listening with audio while you're driving somewhere. I'm going to have a sip of my coffee. We're real people. We're not, um, robots or something here. So, okay. So the objective today for this video is to gain that strong foundation about what menopause is, when it occurs, and the underlying physiology of what's going on with your hormone system. So we're going to talk about premature ovarian insufficiency, early menopause, perimenopause, menopause, and postmenopause. So menopause, as many of you know, is 12 months of no bleeding or 1 year after your final period. So if it's only been 6 months since the last period, you're still not there, right? Menopause is a condition that's not reversible. So when we think about it, if someone has gone that 12 months without the period and has been determined to be in menopause, and then they start bleeding, it's not that they're suddenly, oh, now I'm not in menopause anymore. There might be something going on. And essentially what's happening when menopause happens is that the ovaries stop producing enough hormones to cause that monthly buildup of the lining of the uterus. And when that lining inside the uterus doesn't build up, then it doesn't shed. So you want that shedding each month, and that's not happening anymore in menopause. And the main hormones that we are going to talk about that are affected are estrogen and progesterone. There are certainly other hormones that are affected, but in this video, we are not going to talk about the other multitude of hormones that are affected. Perimenopause is the transition period leading to menopause. This can last for 10 to 15 years for some women. There's actually been some good studies looking at that. So that can be very disappointing in a lot of ways, because when you find out, oh, this is going to last for this many years, what? I don't want to live with these symptoms for that many years, right? So, and then the symptoms we're talking about. With the hormone fluctuations, you can have irregular cycles, hot flashes, night sweats, insomnia, mood changes, and more. Postmenopause is basically anything that comes after you've hit menopause. So when someone says, I'm in menopause, and assuming that it's been 12 months since their last period, then it really means they're actually they're post-menopause. They've hit menopause. They're now post-menopausal, and there are ongoing changes and health implications, which we will discuss. Primary ovarian insufficiency, which we used to call something else. We used to call like premature ovarian failure, which is just such a negative phrase. And I'm glad that this got changed. Primary ovarian insufficiency is really speaking about the ovaries are not producing sufficient amount of hormones. And the reason is just originating from the ovaries. That's what primary means. And this would be something like if a woman who's 35 and is coming in with all the symptoms, hot flashes, night sweats, mood swings, all those things, and they're only 35. So of course, there's going to be a different evaluation for a patient that young. There are some factors that lead to that. There can be genetic factors. It also can be related to having autoimmune disorders. And sometimes it just happens as a result of other medical things that we do to patients, like chemo, surgery, etc. Early menopause then is the period if you go into menopause between 40 and 45. So 40 and 45, if that's when your period completely stops, that's considered early menopause. But perimenopause can certainly begin earlier than that. Perimenopause can begin even as early as that 35-year-old patient we were talking about. But menopause itself, meaning no periods for 12 months, happening before 40 for the primary ovarian insufficiency and before 45 for early menopause. Okay. So average age of menopause is 51 to 52. That appears to be a global number. And then the range is usually 46 to 56. But, there are women, I've had patients myself who've gone even to age 60. I think I saw someone posting that she was 62 and she had just been in menopause for a year. That's certainly possible. Remember, each of you is an individual. You're not going to fit into some cookie cutter mold. Okay. You're not going to experience everything exactly how someone else is going to experience it. Now, how does this impact our lives? We're living to be so much older. Like I plan to live to be 95. I'm 54 and in menopause. And so that's a good chunk of my life is going to be in menopause. Same for you. So how do we make that post-menopause time of our lives the healthiest possible, with the best quality of life that we can have, rather than become, worried about health issues all the time? So there are definitely racial differences in terms of the onset of menopause. Black and Latina women will trend earlier than white women, and Asian women trend later than white women. And same with the symptoms. So Black and Latina women in some studies have symptoms for longer periods of time and maybe even worse severity. Some other factors influencing the timing are smoking, body mass index, genetics, and family history. So actually a smaller body mass index, if you're like really tiny, really, really thin, that could influence you going into menopause or starting your perimenopause earlier. And then, as we mentioned, autoimmune diseases can lead to early menopause or primary ovarian insufficiency, and then genetic causes, which are very rare, and then the iatrogenic surgery, chemo, radiation, of course, can potentially damage the ovaries. Okay, well, if you start having these perimenopausal symptoms early, and there's that threat of menopause happening earlier, and you actually go into menopause earlier. That can be really impactful because you're running around thinking you have another 10 years of fertility, or 5 more years, or 10 more years if you're thinking average age 51, 52, 10 more years maybe of having normal ovarian function, and suddenly you start to have irregular periods, or you can't sleep, you're getting night sweats. So it can be very impactful emotionally. Okay, it can impact your fertility. And then what can happen if your hormone levels are decreasing? So your estrogen levels are decreasing as a result of perimenopause and then menopause. Then that affects bone health, because estrogen causes bone deposition. And without estrogen, you have more bone turnover. So you kind of lose bone mass. So that's also an issue. And then the cardiovascular risks. For whatever reason, there's multiple conjectures. I don't think there's really a solid explanation of how estrogen, or actually, I shouldn't say not a solid, there's multiple explanations for how estrogen lowers the chances of deposition of plaque in the arteries, and therefore lowers the chances of developing coronary artery disease and vascular disease. So, but there's multiple avenues by how that happens. So it's not just one thing. So if you have earlier estrogen loss, you may have higher heart disease risks. And so, in terms of diagnosing early menopause and primary ovarian insufficiency, that would require some lab testing, usually. And the problem is it has to be timed correctly. You want to also rule out other things that could be causing the same symptoms. So, things that can cause similar symptoms would be thyroid disease. That's the most common thing. So, getting your thyroid checked. And I usually recommend not just the TSH, which is the thyroid stimulating hormone, which is released by the brain to stimulate your thyroid gland. But in addition to that, in someone who I'm really suspecting something's going on, I would probably check as well a free thyroxine or a free T4 and a free T3. Now, your doctors are not going to say that you should do that. They usually just recommend a TSH, that if it's abnormal, then a free T4 gets checked. But there's more and more thyroid experts that actually recommend automatically in someone who's got symptoms, not like a screening, but someone who has symptoms, to go ahead and check not just the TSH, but the free T4, which is the free thyroid hormone. There's two kinds. There's T4 and T3. So checking both free T4 and free T3. And then the hormone, the female-based hormones, you would want to check your FSH, follicle stimulating hormone, which is released by the brain to stimulate the ovaries. And preferably that would be checked if the patient's still having periods. You actually would want yourself to get checked, the patient being you. You'd want to get checked on the third day after the period has started. That's a little bit more of something we do when we're looking at fertility, but it's also more likely to give us that information we need. Because if we just draw a random FSH and estradiol, the estrogen level as well, it's just a point in time. And if we do it right after the period for someone who's still having periods, it is right when the follicles are supposed to start to develop for that month. So when that comes back high, then it gives us more information. So if an FSH, follicle stimulating hormone released by the brain to stimulate the ovaries, when that is elevated, let's say it's not in the menopause range, but it's elevated, it tells us, okay, we are no longer functioning in a normal way in terms of fertility. We're headed into that perimenopause time. The estrogen level may still come up normal. So you're balancing, you're taking into account everything about a patient. You're not just looking at just numbers. You yourself are an individual. Remember, you're not just numbers. Okay. It's putting all the information together, numbers, and the symptoms you're having, and maybe family history and your personal history, all of those things together. All right. Okay, so that's kind of the end of this talk. So we talked about menopause, perimenopause, postmenopause, primary ovarian insufficiency and early menopause definitions. We talked about the demographics, and that's it for today. Thank you. I'll see you on the next video.